Mark Grinstaff is a distinguished professor of translational research, biomedical engineering, chemistry, material science, and engineering and medicine, as well as director of the NIH T32 program in biomaterials and the director of the Nanotechnology Innovation Center at Boston University. He has been here for 13 years, I'm sorry, 13 years. His group, I just characterized, I looked through his group and they do so many things. I said, would it be fair to say you invent new materials? He said, well, that's not too bad. He has gotten several distinguished, many accolades. Boston University Innovator of the Year, National Academy of Inventors Charter Fellow, and so on and so forth. He also has published 225 peer-reviewed manuscripts. I figure that's one every 3 weeks, which is pretty good. Yeah, yes, very nice. Anyway, Mark, welcome. Look forward to what that presents.
Thank you very much. It's a pleasure to be here, and it's going to be great to share with you a story from my laboratory. And as it was introduced, I'm interested in materials, and today I'm going to tell you about burn dressings. But the idea of a burn dressing actually started with the eye, of all things. And so I got very interested several years ago about the cornea, thinking about how one can do vision, and then thinking about what happens when you have an injury in the eye. So let's say, for example, you have trauma or infection, or let's say a surgical procedure like a cataract. They make a wound in the eye. And when you make a wound in the eye, what happens is the following. Your intraocular pressure decreases, right? That's what they do. Excuse me. That's what they measure when you go in to do a glaucoma test. All right? So your intraocular pressure decreases. Your anterior chamber collapses, all right? And so this is an emergency. And the standard of care is to actually take a needle and a nylon suture, and they actually suture that wound. And you can imagine suturing that wound is really challenging, right? Because you have this wound here, and as you suture it and you tie it off, you got to make sure that all the stresses are equivalent about this wound, because any asymmetry is going to lead to an astigmatism. So this is a hard problem. So your clinician needs to be smart, they need to be fast, they need to be highly talented, and they got to do it just right. And yet this is really hard to do. And I learned about this problem from talking with some clinicians, and I'm sitting there going, really? This is what you do. You take the individual underneath the microscope and you start suturing it up. And then I say, well, what happens after the healing? And they say, well, the patient comes back and we pull the sutures out. I said, lovely. And then I asked, well, does that cause any damage? And the clinician said, no. And I'm thinking, okay, as a scientist, as an engineer, that's not right, okay? A, you're going to have some injury, and B, this just sounds like a horrible type of thing. So we had the idea to make a glue, an adhesive. And the idea was to replace sutures and come up with something that would be far better. And so a fancy glue, like you would buy at Home Depot or something like that. And the idea is that if you had this wound, and you applied the glue could be elastic enough so that you could have proper remodeling. And then as the eye healed, it would wash away and maybe go away in the tear. And we thought that would be a really cool, both basic science project. It had a nice engineering component to it. And if we were successful, we could actually move it to the clinic. And we did that, all right? We took it from a paper drawing with the student in the laboratory all the way to patients. And now they use it. So it's become standard of care. And what we did when we thought about this was, what type of material do we want to make the glue out of? What type of adhesive? And so we thought about different types of polymer structures. And one that we're very familiar with are long linear polymers, all right? This is what fabrics are made out of, chairs, all sorts of plastics are these long linear polymers. And the problem with long linear polymers, you only have 2 in groups. And I needed lots of in groups because that's how I'm going to connect these polymers together to make a glue. And so we thought about different types of polymer architectures. And one that was pretty exciting was this idea of a branched or a dendritic structure. So in dendritic polymers, just like a tree, it has all these branches that come off. But when you have a branch structure, you have lots of in groups. And so that means we can make polymers, for example, that had lots of in groups, and then we could cross-link them to make gels. So in fact, what we made was Jell-O. It looked like Jell-O, except it was really sticky. All right, so sticky Jell-O. So a double-barrel syringe, you inject it, It seals the tissue. It's looking really, really nice. And one of the nice things about making these kind of fancy dendrimer polymers is I can make them as a single molecular weight polymer. So if you're not a scientist out there or an engineer, that's really cool because, in fact, when you buy a polymer, all right, it says molecular weight is 10,000 grams per mole. But in fact, your bottle has some 5,000, some 7,000, some 10, some 20. It's a distribution. And that means if you use that polymer and you see a mechanical property or a biological response or a physical property, you correlate it back to this distribution of polymers. And that's hard. If you make a single molecular weight polymer, then every effect I see, be it biological or be it mechanical or physical, I can tie to a structure. And that means I can develop these structure-property relationships and actually do it. And so the wound that we went after is a cataract procedure. And so they make an incision in the eye. They go in with this little device, and they basically ultrasound and liquefy your lens. So the reason you have cataracts is become a little cloudy and you can't see clear. So they suck it out. And then they have what looks like a plastic contact lens that has these hooks on it, kind of like this. They put it in there, and then they take the needle out, and they tell you you're done. And it's called a self-seal procedure. Great name for doing nothing, okay? And in your eye, this is okay because you have an intraocular pressure, so it's pushing things out. Because the last thing you want is fluid on the top of your eye to go back into your eye, all right? Because that's where bacteria. We all have bacteria on our hands, faces, everywhere. Staph aureus is a classic one. So the only thing you need to remember from this lecture is if you or family members ever have a cataract procedure, never touch your eye. It's the only thing you need to remember from this lecture, okay? That's it. Everything else doesn't matter. Just don't touch your eye, all right? And so that was the procedure. There's about 1 million of those done every year. And so to do this, we actually had to form a company, all right? And so we recruited a bunch of business people, regulatory, built a team, made a product, did a clinical trial, and it made it through it. And that made us think about doing other types of sealants. So we just made a dura sealant, so when you have brain cancer. We have a spinal sealant, so when they do like a spinal tap. We have a hernia mesh sealant, all right? So it's a really cool set of technology that allowed us to think about all these things. And of course, when you're doing all this, you have to get everything just right to get it into the clinic. And I'll tell you an embarrassing but funny story. So we're in the midst of trying to raise some money, and we're meeting a number of different companies and telling them about this product. And it's a very simple idea. We have a double-barrel syringe, and the fluids come out, and they mix. It comes out of a needle and forms a gel. And we couldn't get the mixing right. And we're trying, and everybody in the lab is working, and we just can't get it to work. And I'm like, oh my goodness, we're going to be in Texas in a day and a half, and this is not working. And one of the people in the company says, well, you know, if we use this ultracentrifuge, which is this big thing that spins things really quickly, you can actually dissolve it really well. And I said, well, that's nice, but we don't have one of those. So we keep working, we can't figure it out. So I do what's logical. I go to the airport in the morning with my briefcase and a centrifuge. So I literally picked up the centrifuge. It's about 50 pounds. That was my carry-on luggage. So I walked up, I put it on the belt. The gentleman asked me, what is it? I said, it's a centrifuge. He says, that's fine. And goes through, and I walk through, and I'm like, this is totally nuts. You know, how do you know anyway? So I had this crazy thing going through the centrifuge. Anyway, things worked out really well. And so we did that project, and several years went by, and we didn't do too much in this area. And then I got interested in another problem, and that was burns, all right, and how you treat different types of burns. So today, about 300,000 individuals are burned, okay, every year. And there's 3 types of burns, kind of first-degree burn, which would just be nothing more than like a bad sunburn. Second-degree burns, where it's really quite nasty, all right? You have a lot of tissue loss, but you have a lot of nerve endings that are still present. And then you have a third-degree burn, which is extremely bad. It kind of goes down to the bone, but that one actually doesn't hurt so much because you don't have any nerve endings, all right? So this problem became even more interesting because I got to talk with some pediatric burn specialists, and I learned about what they actually do for children, and this is just crazy. All right, so standard of care today is the following. So about 300 children make it to the emergency room every day in the US. 2 actually die, so this is a real big problem. And standard of care is after they've cleaned the wound, they put on a dressing. And then they have to change the dressing. All right? And to change the dressing, they basically take a knife and a mechanical device and they rip it off the skin. And that causes a huge amount of pain. So the pain comes from these multiple bandages being changed daily, weekly, and all this. So for children, they actually anesthetize them, do the procedure, and wake them up. You know, if you have a 20% burn on your body, that's 3 people and an hour and 20 minutes of work. All right, so this is difficult, it's challenging, and it's really painful. So we had the interesting idea of, could we design a material, a glue, but now we'll call it a dressing. And the idea is, could we take this dressing and spray it on the wound and have it seal it and protect it? But then instead of cutting it off, we'll take a second solution, spray it, and have it dissolve. Kind of like on-demand dissolution of a dressing. And if we could do that, maybe we'd actually reduce the pain and make the procedure easier. So this is a neat idea. So I walk into the lab, grab my students, and we start talking. They're all looking at me like, you're a little nuts. You know, how are you going to do this? And so we sit down and we think about the chemistry, we think about the engineering aspects, we talk to the clinicians, and we come up with a prototype. All right, so we make something, comes out of a spray can, and you can spray it on, and sure enough, it makes a good seal, and in fact, it seals the wound. That's good because you want to have a moist environment for it to heal itself. You want it to absorb fluid because the wound has actually got some exudate, so there's some fluid coming out, so you want to swell that. All right, but it's got to be strong enough that it can stay in place. All right, it would be really good if it could actually prevent an infection. So in other words, if bacteria got on the top of that wound, all right, with the bandage, they wouldn't be able to get through. Okay, and we did that. And so we actually created the structure, and again, it used one of these dendron polymers, all right, and they come together and they cross-link, but now the linking part here is a really unique bond. It's a thiol ester. And we can add, for example, just cysteine, which is an amino acid, and it will cause those two to come apart. And it comes fairly rapidly. And so now we have a way of actually applying it and then watching the healing, preventing the bacterial infections, and then a way to dissolve it. And so this is our next big challenge in the lab. Like, how do we actually get this to the clinic? How do I make a difference for this? How do we do this really cool kind of basic studies? And so once again, we're assembling a team. We have a graduate student and a postdoc on this project that are here at BU. We collaborate with a trauma surgeon over at Beth Israel Deaconess Hospital, as well as at the Shriners Burn Center, bringing all this expertise together so we can all work on a problem. Because it's really hard for just one person to actually solve something. What it really takes is this team effort and all these different expertises coming to the table. All right? And this started with a single student, just like you. It's not a lot of people. It's me speaking with a student, having a crazy idea, and that student taking that idea and making it a reality. And to me, that's an exciting thing about being at BU. It's an exciting thing about doing research and having that flexibility to think about really interesting problems. And so with that, that's it for my presentation. So thank you very much.
If there are questions, we have a moving microphone which will find you.
And you can ask me almost anything, so I'm game. If you want to know about science, engineering, the clinical part, what's it like to do a startup, I can try to answer almost anything.
I ask a question, but I don't need the microphone. So I cut my thumb and I actually had glue. Was that one of your glues?
No, it's not. So that's J&J's glue.
Oh,
okay, a competitor. But that's it's called Liquid Bandage is one of the products out there. It's a great product. It's actually super glue.
That's what it felt like.
Yeah, and so it's great. If you have a bad cut, you should use it. It'll prevent blood loss. That's the big problem when you have a cut, is to stop the bleeding. So I think it's a great product. It's not a product that you would use internal. All right, it degrades. It generates a number of nasty byproducts. So it's something that just be topical, and it works really quite nice for the same reasons. It keeps something moist, it protects it, and then it'll basically slough off over time. Yes, way in the back.
How's it going? I'm Andrew.
Hi, Andrew.
So I work with compounds also, and I know that when you put molecules in a biological environment, they can often degrade over time, like a half-life. You're comparing these to plastics, which the half-life is forever, as we all know. So I was wondering if you had a half-life for your compound, and
Sure.
yeah.
Sure. So it's very much, as you can imagine, that's something we want to tune. So you can imagine if we're making a material, for example, for the eye, and I need to seal a corneal wound. In fact, cornea is a really nice problem to do first, because basically when you have the intraocular pressure come back up, you have pressure that holds the tissue together. So all I have to do is almost just have a very weak interaction and hold that tissue. The cornea will remodel itself in about a day and a half. And so in fact, the sealant stays on top of the eye. The cornea basically regrows itself. And then as it starts to degrade, your eye movement, when you blink, and the fluid you generate is going to wash it off. So there I needed something that could last for 3 or 4 days. And the way you vary that is on the number of cross-links you have. If I'm doing something for the dura, all right, so we've opened up your skull. You have the brain exposed. You put the polymer on that. You put the bone back on that, all right? There I need something that's going to stay a lot longer. And so we can change our cross-linking density so that we can vary the time there. So again, it's about thinking about what are the design specifications that you need to meet, and then how do you go about designing material that might do that.
I have a quick question from an intellectual property perspective. Were you able to get some of your products patented?
Oh yeah, they have to be.
Fantastic.
They have to be, because anytime we want to translate a technology out, someone's going to need to take some risk and put in some money and do that investment. And what they're investing in is the IP, the intellectual property for that, and the team. And it's the combination of the two of those that actually make it successful. So it's really hard to move something into the clinic if you don't have that intellectual property, the patents that are associated with it. So, got to do it. It's important to do. And it's in the Constitution. We should be competitive. It's great.
I was just wondering, how much does this dressing cost for either the cornea or for burn victims?
Yeah.
So is it something that's manageable if you have a first-degree burn? Or is it something that you'd really only use with a third or second degree?
Yeah. Okay, so I can tell you for the cornea product, it competes at the same price as sutures. So it's like 20-something bucks. Okay, so that's pretty good. So that's kind of more, going out as a commodity item. The Dura sealant, that's a much smaller market, and we need different types of design specifications. That's more several $100s for that product, okay? The burn dressing, we don't have a price yet on that, but I'd like to compete with current burn dressings, and those range anywhere from about, $50 to $120 per dressing. So I think if we can get in that range, not only can we provide a better product, but we can have something that would be competitive on the market. Great. Thank you very much.